Management: antibiotics. If patient has fever, temperature more than 100 degrees Fahrenheit, or abdominal pain or tenderness, empiric antibiotics should be given even if neutrophil count less than 250 cells per cube. Treatment focuses on appropriate antibiotic therapy. A third-generation cephalosporin is the treatment of choice as they are typically effective in covering the three most common isolates from infected acidic fluid, that are Escherichia coli, Klebsiella pneumonia, and Streptococcus pneumonia. For example, ceftriaxone 25 mg/kg up to 2 grams daily, cefotaxime 25 mg/kg up to 1 gram Q8. There are also alternate antibiotic choices: ciprofloxacin 400 mg 4 BD, levofloxacin 750 mg 4 daily, piperacillin, tazobactam 4.5 grams 4 TDS, ertapenem 1 gram 4 QD, imipenem, cylostatin 500 mg for kid. Note: patients with a single episode of SBP should be considered for antibiotic prophylaxis, with norfloxacin, ciprofloxacin NOR-TMP, SMX. Number 2. Albumin infusion, recommended by American Association for the Study of Liver Disease, AASLD, in specific subgroups with SBP. The benefit of albumin infusion in SBP is not entirely known. Although multiple possible mechanisms have been identified, albumin has been demonstrated to mitigate entotoxemia, block lipopolysaccharide-stimulated neutrophil activity, and modulate nitric oxide activity, mitigating systemic vasodilation and capillary leak. Presence of any of the following should prompt albumin administration: serum creatinine more than 1 mg/dl, blood urea nitrogen, BUN, more than 30 mg/dl, total bilirubin more than 4 mg/dl. Impact of albumin infusion: 25% reduction in renal failure, 20% reducing in mortality. Dose: 1.5 grams kg within 6 hours, 1.0 grams kg on day 3 of treatment. The guidelines: the 2012 AASLD guidelines, based largely on the trial by Sword, et al., recommend that patients with acidic fluid PMN counts greater than or equal to 250 cells/M3 and clinical suspicion of SBP, who also have a serum creatinine more than 1 mg/dl, blood urea nitrogen more than 30 mg/dl, or total bilirubin more than 4 mg/dl should receive 4 albumin, 1.5 grams/kg, within 6 hours of detection and 1.0 grams/kg on day 3. Approach to diagnosis and treatment of spontaneous bacterial peritonitis. On diagnostic paracentesis test result, we will look at acidic fluid DLC and DLC, acidic fluid bacterial culture inoculated at bedside. If the results show that neutrophils are more than or equal to 250 cells per millimeter cube, then we will presume SBP and start therapy with antibiotics and albumin following guidelines, without further delay for culture results. If culture result is positive, then SBP is confirmed. So we'll narrow antibiotic therapy based on susceptibility results to complete the antibiotic course in 5 days. If culture result is negative, we will still complete the antibiotic course for 5 days. On the other hand, if neutrophils are less than indicated, we will look for signs or symptoms of infection. If they are present, patient will still begin antibiotic therapy for SBP. If they are absent, then we will wait for culture results. If culture is positive despite above negations, we will repeat the diagnostic tap for culture to confirm it again. If culture is negative, no antibiotics are indicated.